Case number 6 is a 65-year-old patient who presented with sudden onset abdominal pain, nausea, and vomiting. He has not had any prior abdominal surgeries, and there were no prior radiographs for comparison. On physical examination, the abdomen was diffusely tender to palpation, there was scarring in all four quadrants, and the bowel sounds were diminished in frequency and intensity. On laboratory investigation, his white count was quite elevated, as well as his CRP, and he also had an elevated lactate up to 8.5. Here we're presented with 3 radiographs of this patient. On radiograph, we can see that there are multiple dilated small bowel loops. And we know that these are small bowel loops because the dilated loops contain these linings that go through the entirety of the bowel. These are called valvulae conniventae, which is a signature for small bowel loops. On a closer look, we can say that there is no obvious free intraperitoneal air, there's no pneumatosis intestinalis or portovenous gas, which we'll go into with more detail on a later slide. There's also a left total hip prosthesis in place. I would like to share with you my simplified approach to abdominal radiographs. I like to use the ABC method, where air stands for extraluminal air. You're looking especially for free intraperitoneal air, pneumatosis intestinalis, or portovenous gas. B stands for the bowel, and I'm sure you've heard the 369 rule, where the small bowel should be less than 3 centimeters in diameter, large bowel should be less than 6 centimeters, and the cecum should be less than 9 centimeters. C stands for abnormal calcifications, such as calcified aneurysms, renal, bladder, gallbladder, stones, etc. And there's other things to look for, such as bones, lung bases, abnormal soft tissue densities, and etc. With small bowel obstruction, this accounts for 80% of all intestinal obstruction. Patients typically present with cramping abdominal pain, abdominal distension, nausea, and vomiting. And it typically results from some lesion which obstructs the bowel lumen, and up to the point of obstruction, also called the transitional point, the small bowel becomes dilated as the swallowed air is unable to get past through the point of obstruction due to lack of peristalsis. The most common causes of small bowel obstruction include post-surgical adhesions in surgical patients. Hernia are the most common cause in patients without prior surgery. Other slightly more uncommon causes include malignancy, inflammatory bowel disease, gallstone ileus, or intussusception. The CT features of small bowel obstruction include dilated small bowel loops up to 2.5 to 3 centimeters or greater than that. Collapsed bowel loops are often seen more distally past the transition point, and there can be something called the small bowel feces sign. Here is a CT case of someone who had small bowel obstruction secondary to a suprapubic hernia. You can see all this dilated loops of small bowel. And as we go into this hernia sac, if you follow this loop of bowel, you can see eventually it becomes more collapsed distally. So this suprapubic hernia represents the transition point where the dilated bowel loop gets to the point of obstruction here, and the bowel loops more downstream becomes more collapsed. And more proximally to the point of dilation or its transition point, you can see this loop of bowel containing fluid intermixed with air, producing something called the small bowel feces sign. In terms of signs of bowel ischemia, it's important to look for these with any small bowel obstruction. These include portovenous gas, which involves accumulation of gas within the portal veins and its branches. These are seen as these linear tubular branching lucencies within the liver. You can also get something called pneumatosis intestinalis. This is gas within the small bowel wall. And you see these curvilinear circumferential gas lucencies within the expected location of the small bowel wall. Can also get free intraperitoneal air, which may be a sign of small bowel perforation. This can appear as air that's superimposed between the liver and small bowel loops, as in this case. Sometimes you see air that's right underneath the diaphragm. You can also get something called the wriggler sign. This is free intraperitoneal air that becomes trapped within the small bowel loops, and as a result, it outlines both sides of a bowel wall. So here is a small bowel wall, and here is another bowel wall, and you see this abnormal air. And similarly here, this is the small bowel loop and another small bowel loop, and you see this air density projected within the two loops of small bowel. So this is case number 6, a case of small bowel obstruction.